Welcome back, everybody. My name is Sean Works, and I want to share with you all today something that the news probably isn't doing a very good job explaining, and that is how the Wuhan coronavirus is spreading, what to understand about it in its pathophysiology, and what you can do with it, and what you need to know. A wealth of information is what we need to understand as we're looking at what's going on here. And so I want you to see the news report here. Some analysts project over, in the wake of the deadly virus, at least 106 people have died from the outbreak, with close to 3,000 that have been infected. 5 cases have been reported in the U.S., although more than 100 cases are being investigated. So if you see here from NBC News, more than 100 tested for the coronavirus in the U.S., but just 5 cases have been confirmed. So where are those cases being confirmed at? We have cases in Washington, Illinois, Arizona, and 2 in California. So they're coming over on the Pacific coast. And so I want to share with you all what you need to know scientifically about the coronavirus. And this will help you understand how to best go about preparing you and your families for dealing with it. I want to share with you research done by Dr. Mark Olfert. He's Associate Professor in the Human Performance Department of the Exercise Physiology program in the School of Medicine at West Virginia University. So Dr. Olfert has a PhD. He's a respiratory physiologist, and he does research with lung physiology and pathophysiologies that affect the lungs in neonates and different populations. And so this is coming from his research. This is his presentation. You can contact Dr. Mark Olfert through these avenues of contact, through his office phone or his email at the School of Medicine at WVU School of Medicine. And so I want to share with you some information. And this information is also pulled from the book, Essentials of Pathophysiology. The authors of that book are Porth, and it was the 2nd edition. And so the chapters that talk about respiratory physiology, different kinds of infections, and respiratory exchange disorders are chapters 21 through 23, as well as chapter 12. And so I want to share with you all here. We'll get right into it so you understand what's going on. The lung is the only organ other than the heart to receive the entire cardiac output. Functions of the lung primarily is to perform gas exchange. They also filter with the blood and the air, and they capture inhaled particles. They break down vasoactive substances. These are substances that act in the cardiovascular system, vasodilators, vasoconstrictors, things that act on the kidneys, and also for speaking, air being forced through the vocal cords. The respiratory tract, we consider here we're looking at how the coronavirus can infect the human body, and they often have a mode of going through the respiratory tract. Research right now, the Wuhan scientists are not sure if the respiratory pathway is the only pathway the coronavirus can be spread. Scientists are now looking to see if it can spread through the eyes and also through touch contact. Somebody can sneeze, have particulate on their hands, and they can scratch their nose or their eyes or their mouth, and then they can be infected that way. The research on that is not yet completely figured out, but they're considering all options of transfer for the disease. So looking at respiratory tract infections, the lungs have a very large surface area. From a child to an adult, 50 to 100 square meters worth of exposed tissue to the atmosphere. The lung cells are made up of the epithelial tissue, and so if you were to spread them out onto a sheet in a flat surface, they would actually come to the size of about half a tennis court for one single human being. So that's how much surface area is in the lungs, which means they are very susceptible to infections, respiratory infections of all kinds. And so we're going to look at how this goes here. The respiratory tract is particularly perceptible to respiratory viruses. And so we have 2 kinds of respiratory viruses. This is the common viral structure, from the common cold all the way to the influenza. Most viruses have a DNA or RNA nucleic acid genome, where they're surrounded by a capsid. And this DNA capsid structure forms a viron. And the viron is what enters the body and can infect and attach to cells and insert its DNA to those cells. Some special viruses have what's called an envelope, which is a special waxy capsule. These viruses are harder to kill as this waxy envelope is impervious to pH. There are different drugs that treat normal viruses are not effective in breaking down this barrier. One of the most common ones that have this surface is the tuberculosis viron, which is why tuberculosis is very difficult to treat. But we do have ways to stay the virus to arrest its progression in people with tuberculosis. And it's a 4-drug cocktail that takes anywhere from 9 months to 15 months to treat, depending on whether or not the person is immunocompromised. So here are different forms of viruses. You see the notorious Ebola virus, the HIV virus, the H1N1 virids. And so these structures all have the RNA or DNA viral cores surrounded by capsids, and they have these little glycoproteins on their surface, which are docking receptors that can attach to specific cells in the human body. So this is what makes them particular or specialized to certain places in the body to cause an infection. If we look at them on a closer scale, viruses can't proofread their DNA or RNA. So their errors are much higher. So viruses are prone to DNA or RNA replication error and require a host to replicate, meaning without a host they cannot replicate, but viruses constantly mutate every year, which is why there are different variant strains of the flu. There are different variant strains of the coronavirus. So the host cell cannot discern between the viral DNA that's being inserted from the virus that comes in versus its own DNA. So when this DNA is incorporated into the nucleus, which contains your human DNA, you have things like reverse transcriptase, which is an enzyme that takes their RNA, turns it back into DNA, and inserts it into the genome, in short. That's a simple way of looking at it. So these common colds are how all of these viruses appear or manifest as with the very first formation of symptoms. You have things like the rhinovirus, the parainfluenza virus, the respiratory syncytial virus, and the coronavirus and adenovirus. We are looking at the coronavirus here, but to understand that, we have to understand some basic physiology of the viral structure and of the human body and the lungs. So these multiple viruses, rhinoviruses particularly affect the younger generations and occur in the early fall and late spring, which is why this time of year is considered flu season, which is also an umbrella term for really all of these kinds of viruses. The influenza virus generally attacks younger children. Respiratory syncytial virus, winter and spring, younger children. Coronavirus. Notice there's no research saying that the coronavirus can only infect infants. Both young and old are susceptible to coronaviruses and adenoviruses. These typically affect the upper respiratory tract. It's seasonal, again, flu season. And treatment for viruses is mostly palliative. We treat its symptoms. Okay, so when something says it's palliative, we're just treating the symptoms. Most viruses are palliative. Most medications we have today can reduce the symptoms or arrest the symptoms from progressing, but they don't really have a way to treat some of these viruses once they're in the body. The body has to weed them out. Like I said, the viruses lack RNA proofreading enzymes. So their error in the viral genome is 10,000 every 10,000 nucleotides. So it's a very high error rate. How do we know that? If you compare it to the human genome, we have so many replication proofreading enzymes such as helicases and topoisomerases that uncoil these things, and you have polymerases 1, 2, and 3 that go back and check and recheck and check again to make sure everything was coded and paired correctly. But here, normal replication error is 1 per 10 million in a human cell, whereas viruses have replication 1 every 10,000 pairs of these nucleotides in their RNA or DNA cores. So they're prone to replication errors. Typically affects upper respiratory tract, and so as we know it's palliative care. There are new vaccines every year due to many different serotypes. And so what you need to know, number one, about treatment with the coronavirus. Going to the doctor and asking for an antibiotic will be ineffective. Viruses have different ways of infecting the body. Their pathophysiology is different, and they are not the same as bacteria. Antibiotics are for bacteria. They are not for viruses. So we have a problem with the overabuse of antibiotics, and we are seeing antibiotic-resistant bacteria infections in hospitals, something known as sepsis, which is a system-wide infection in the blood from bacteria that occurs in many hospital patients, and it's not always reported, but sepsis is a high cause of death in these hospitals, especially when the patient becomes antibiotic resistant, because the bacteria are so quickly adapting to the exposure of antibiotics that we've now been using for the last 50 years. So mortality due to the common cold is very low, normally low in a healthy population, and the emphasis is on healthy. Elderly, young, and immunocompromised are most vulnerable. So people who are immunocompromised are people who may be carriers of the HIV virus, people who are have undergone a kidney transplant, a liver transplant. You are put on medications to suppress the immune system so you don't reject the transplant graft of somebody else's tissue. People who have cancer go through chemotherapy or immunotherapies. These are all people who are going to be more susceptible to the disease or the infection of the virus, the youth and the elderly and the immunocompromised. Why is this important? The coronavirus itself is not what causes the fatal event in somebody. The coronaviruses and the influenza viruses can cause what is a condition in the lungs called severe acute respiratory syndrome, or SARS. So when you hear the word SARS, understand it's a severe, acute, or sudden onset respiratory in the lungs syndrome. The word syndrome in pathophysiology means it has a defined set of symptoms and signs that are always testable and always occur with this particular onset of a pathology. The number one pathogen that causes SARS is the coronavirus. This is why the coronavirus can become so deadly. If it mutates and it becomes a more potent variant, that variant is more prone to causing SARS in the human body. So we're going to understand more about SARS here as we go on. The first time this became a pandemic, which was in Asia, North America, was in 2003. The SARS pandemic resulted in an atypical viral pneumonia and severe respiratory distress. So when you see pneumonia, which is the inflammation of the lungs and the accumulation of fluid and edema in those lung cavities, atypical means viral. If you see typical pneumonia, that means bacterial pneumonia. But atypical pneumonia is a result of a viral infection, such as a coronavirus infection. There's a 10% fatality rate that was first caused by this first mutation of the coronavirus in 2003, the World Health Organization. Again, antibiotics weren't effective in the treatment of the coronavirus at the time in 2004. We know this because of a World Health Organization physician, Dr. Carlo Urbani. Here's his picture, first to diagnose SARS in a 48-year-old businessman traveling from China to Hong Kong to Hanoi, Vietnam on February 26, 2003. Unfortunately, due to his humanitarian efforts in working for the World Health Organization, trying to understand how SARS forms in the body and how it is transferred through these coronaviruses, he contracted SARS himself and went into lung failure, and he died on March 28, 2003. Most people who contract SARS do not recover, and we're going to see why. When we consider how these viruses spread or how they mutate or how they're named, we hear things like the H1N1, the H5N3, the flu A, flu B, flu type C. The typing is actually a reference to how those viruses look like under an electron microscope. And so those viral capsids contain surface proteins called glycoproteins, glyco short for glycogen proteins. So you have a protein structure with an amino group, and you have a glycogen structure on it, which is a complex branched sugar molecule. And so the sugar slash protein combinatory elements on these viral capsules are what give the viruses their unique fingerprint. And so that's how they are typed and categorized and sorted in the academic world. So you have two serotypes that can be used to diagnose or to classify a viral surface glycoprotein, the HA and the NA. So the hemagglutinin, which there are 1 through 16 types of HAs, and the neuroaminidase surface proteins are numbered 1 to 9. So combinatory, you have 16 of these and 9 of these that can form on any viral surface. So if you have H1N1, that means it had one of these and one of those. But it could be H16N1, it could be HN16N9. And so there are many, many different combinations of these viruses that can form due to mutations. And we know viruses are already prone to mutating because they have no DNA or RNA proofreading enzymes. Viruses also contain an M2 ion channel, which controls the pH of the viral core, and it is responsible for disassembling and releasing the viral RNA and core proteins once inside the host cell. And the host cell are your human cells. Depending on which virus has what surface glycoprotein, depends on where they end up in the body. So that's why influenzas and coronaviruses and syncytial viruses, their glycoproteins are similar to the glycoproteins of the cells in the lungs and the respiratory tract. Whereas the HIV viruses, they have these receptors that are similar to the ones on the human immune cells, particularly the T cells, the CD4 and the CD8 cells. And so it binds to those and affects your immune cells. The H's 1 through 3 and N2 and N1 are the most commonly ones that are affecting humans. H's 4, 5 through 16 and others are ones that are found in animal diseases. But mutations can occur, like in the swine flu, where that H type actually was transferred to a human genome and is susceptible to a human. And so we see the classifications of these diseases here. The bird flu was an H5N1, the avian bird flu, which came about from China. It mutated. The swine flu, H1N1, 2009. The Hong Kong flu, 1968, H3N2. So you see the variants. What we see here, these viral influenzas affect upper and lower respiratory tracts, and they had similar symptoms to the cold. However, these were much more aggressive, and what made them aggressive was they were more prone to ARDS, or respiratory distress syndrome, which is what the SARS was, sudden acute respiratory distress syndrome. When we look at the influenza virus and how it spreads, so here's an animal cell, here's a virus right here. It docks on a surface glycoprotein. It's enveloped in endocytosed. It's brought into the cell here. It penetrates the barrier. It uncoats. The uncoating unravels, and that uncoating then begins replicating its own DNA. Here's the human DNA core. Here's the viral DNA core. Once these proteins are broken apart, they are taken into the nucleus by enzymes like reverse transcriptase, placed into the DNA, and then they are replicated and they mature and reproduce mature viral DNA capsids. These change the cytosolic environment in the cell. It causes or triggers what is called cell apoptosis or host cell lysis, which is like Lysol is used to lyse these bacteria and viruses. But here they lyse the human cells. The cell explodes and it shoots the fragments of the virus or the viral capsids into the bloodstream or the lungs or whatever it is, and the process repeats, killing more and more cells as they replicate. They can also bud off one at a time until the cell becomes so small that it dies. So influenza, remember we said they affect upper and lower respiratory tracts. What does that mean? If you look at the lung, so here's your mouth over here, and you breathe into it, You breathe in air and you come down the airways through the trachea and then you have what is called the bronchus, which is the large air tract. Then you have the bronchiole, which are the small limbs of the tree, and you have the alveoli, which are the little buds that look like little grape pockets that you can picture in your mind. So these three tiers of lung physiology here. So the upper way is the bronchus and the bronchiole. So this is when you can feel it on the top of your chest. You want to beat your chest. You feel like you're coughing stuff up. Your breathing is labored here. The airways are inflamed. And so they're each made up of specific kinds of cells. And this is the upper airway. And if you're going to get a respiratory infection, you want it in the upper airway. What happens is, as the virus replicates, it moves down into the lower airway into what is known as the alveoli, or singular alveolus. This is the functional parenchymal tissue of the lungs, and here is where an infection causes pneumonia. Once pneumonia sets in, now the mortality rate of that particular virus becomes higher, because pneumonia can lead to the ARDS, the respiratory distress syndrome. So in terms of modern allopathic medicine, scientists and chemists and pharmacologists have come up with different kinds of drugs. You have Zanemivar, which is Relenza. These are the trade names. Tamiflu, which is common, but I know one time I went to the doctor and the Tamiflu with health insurance was still $126 to buy a prescription of Tamiflu. You have Simitrel and Flumadine. Doctors, and if you go into the hospital and you have the flu, you're automatically put on a Tamiflu drip. And so what these do is, here these are neuraminidase inhibitors, and here these prevent uncoating with the M2 ion channel. So you have multiple avenues of attack to stop the virus that scientists are coming up with. So here, the neuraminidase inhibitors prevent the virus from budding off and spreading. So they prevent it from spreading, but they don't stop the virus that's already there. So it's not a cure-all. This is why they're often treated in combination with Simitrel or Flumadine, and these prevent the unloading of the viral RNA into the host cell. They prevent this part of the hemisphere of the life cycle of the virus. They prevent the unloading of the viral RNA. However, they're not cure-alls. And they're not all, people respond differently to different medications, correct? And so you see here how you want the upper airways are the nose, the sinuses in the head, the back of the mouth, the trachea, and the bronchioles right in here. These are the upper airways. Easily spread, rarely fatal. And this is it's bad that it's easily spread because it's aerosolized. You're sneezing, you're coughing, you're spreading aerosolized viroids in your breath, but your lungs are vastly unscathed on these alveolar sacs here. And so you're not probably going to die. However, such as the H5N1, which was the bird flu, it travels deeper into the lungs. So it's not up here, so it doesn't spread as quickly, but it is more fatal. The human who carries this is more prone to developing pneumonia, and without treatment, pneumonia can develop into respiratory distress syndrome, especially in somebody who is immunocompromised. Every year, the leading cause of death in America is heart disease. It used to not be heart disease, but that's quickly gone to the top in the last 10 years, 20 years. Then cancer, stroke, respiratory diseases, chronic lower respiratory diseases. So this is like bronchiectasis, COPD, chronic obstructive pulmonary disease, bronchiectasis, asthma. These are chronic diseases that result from either a congenital or genetic defect from birth or from smoking. Smoking is the number one cause of a lower respiratory distress disease because of the chemicals in smoking. And Dr. Olfert, I'll put in his research lab for respiratory diseases, he has been studying the effects of vaping on young people and looking at tissues in the lungs of mice who've been exposed to vaping smoke and how they actually develop many similar pathologies as smoking regular nicotine-laden cigarettes. And so they are not any safer than smoking themselves are. And you can look up his research in his reported journals on PubMed and stuff from Dr. Mark Olfert to see what he's doing and finding out here. He's leading the way in this forefront in his research. Then you have influenza and pneumonia. These are the viral infections, which are different from the chronic infections. These are acute, these are chronic. Still 52,000 people a year die from flu and pneumonia. And when you have spikes of mutated coronaviruses, this number jumps for that year as well. You see how easily, when you talk about upper respiratory tract infections, these people with slow motion cameras capture the sneeze of individuals as they're sneezing, how aerosolized particles go into the atmosphere and can land on surfaces, and those viruses can live for several hours to several days, depending on the surface, whether or not it was treated, depending on the humidity in the room and the pH of the surface they landed on. So this is how it spreads, which is why the coronavirus is also a contact precaution in the hospitals. The physicians have to wear gloves, masks, goggles, complete gowns, because these particles can lie on surfaces of the skin or the body or tables and can also be transported through contact. So when the coronavirus mutates into pneumonia, infection or inflammation of the lung, which is the parenchymal, which is the alveoli and small airways. Remember, this is the lower portions of the lung tissues. This parenchyma is Latin for the main functioning unit. The parenchymal tissue in the kidney are the nephrons. The parenchymal tissue in the lungs are the alveoli, which are these grape-like sacs where gas exchange takes place across a one-cell membrane barrier, and you have the blood and the capillary beds on the other side of these tissues, where the body gives off carbon dioxide in exchange for oxygen coming in through the lungs. Alveoli in Latin means little cavity. And so here you see the alveolar space. You see the membrane here for the alveolar tissue. This is one cell thick, and you see the blood pathway, the blood capillary beds around it. And you see some tiny immune cells here on the periphery as well. So this is where carbon dioxide and oxygen exchange in the lungs. And remember, we're studying why the coronavirus is so deadly. When it hijacks the body's ability to breathe, you cannot survive without oxygen but a few seconds. You can survive about depending on the health of the human body, a couple days without water and up to 40 days without food. But oxygen you'll die within minutes without. And so that's what makes these respiratory viruses so dangerous, and why even they can bring down healthy people if they allow themselves to be exposed to these viruses, and they're opportunistic viruses. They'll take any opportunity they can get. So pneumonia is classified by a number of ways, either the causative agent and both the location in the lung, lobar versus bronchial. So causative agent, remember I shared typical bacterial pneumonia is pneumonia from bacteria. And so here you see different species of bacteria that can cause the bacterial infection of pneumonia. Then you have the atypical, or the viral and mycoplasma pneumonia. So mycoplasms are a class of hybrid bacteria that have the waxy envelope around them, such as Mycobacterium tuberculosis, so tuberculosis. And so they can also cause pneumonia infections. You see the names here. Legionella is one of these. The non-infectious agents, you can have gastric secretions, chlorine gas, mustard gas, and secondary drowning. So these tissues cause severe inflammation in the lungs and the airways. They cause leukocytic migration. The gap junctions between the cells contract. Those junctions open, fluid enters into the pulmonary space, and the lungs literally drown from a non-infectious agent exposure, such as stomach acid, chlorine gas, mustard gas, or secondary drowning from chemicals. And so these are all ways pneumonia can develop, and here we're particularly focusing on the viral or atypical pneumonia from coronavirus. If you look at locationality, lobar pneumonia means it affects one particular lobe. So the right side of the right lung actually has 3 lobes, and the left lung is divided into 2 lobes. And so lobar pneumonia is typically one particular localized area in a lobe, whereas bronchopneumonia is every bronchiole, which are the trunks here, the tree trunks, has been infected with that inflammatory pneumonia and the fluid filling the lungs and preventing gas exchange. So the third classification of pneumonia is what is called environmental pneumonia. And so you can have community outside at Walmart, in your house, where you live and work, versus a hospital-borne infection. So if it comes from the hospital, the word is called nosocomial. So if somebody has nosocomial atypical pneumonia, that means they acquired pneumonia in the hospital and it is virally based. So typical lobar nosocomial infection means bacterial based, lobar, it's localized to one lobe, nosocomial comes from the hospital, and the infection it's bacterial pneumonia. So this is how the terminology that you will see used describing these events in hospital settings. Atypical pneumonia, viral, and mycoplasma. This is what we want to consider here. More commonly seen in children and young adults. Those who have chickenpox pneumonia, which is an aggressive form of pneumonia, or SARS, severe acute respiratory syndrome. Usually diffuse, poorly consolidated in the lung. Symptoms appear to a similar cold. Agents causing atypical pneumonia impair or damage the host defense, so they impair your immune system, often leading to bacterial infections. So the bacteria in the lungs are opportunistic, and as the viral agent consumes the attention of the host, the host's immune system, the bacteria can get out of control, and you develop also a bacterial pneumonia, which can lead to sepsis, which is a system-wide blood-borne infection, because all blood goes to the lungs. So you see why now these coronavirus infections are so deadly. They can affect the viral system, shut down the immune system, the bacteria in the body runs rampant, you get a bacterial pneumonia infection, the blood's being pumped to the lungs, those membranes are being broken down to the infection and the inflammation, the bacteria seeps into the blood circulates through the body, and you have sepsis, which can lead to kidney failure and liver failure, and can also lead into cerebral encephalitis, and which can shut down the brain, cause seizures, and at that point, sudden death can occur. So when at this point of treatment, they'll administer antibiotics for the bacterial pneumonia and the antiviral drugs like Tamiflu and furosemide for the viral pneumonia. Because remember, regular antibiotics are ineffective against viral infections. In people who are looking at these bacterial infections with the acute cough, there was a study published by these doctors and researchers from the university here in the medical microbiology and hospital hygiene department. It says they were looking at sputum color, which is your spit, what you hack up out of your throat when you're sick, and the biological evidence of bacterial infection. So they looked at people who had a bacterial infection. 16% had a yellow or green mucus production, whereas 5.7% in the sample population who were sick had color sputum. So just because your mucus is clear does not mean you don't have an infection. Some people with clear mucus are still infected with a virus. And so remember that. Just because your mucus is not colored, it doesn't mean you're not a carrier and you have that bacterial or viral infection in the lungs, especially when you have an acute cough that has developed within 24 to 48 hours. And you see their conclusions here. So finally, we get to acute respiratory distress syndrome. There's 5 slides left, and I want to cover this time now of how coronaviruses, the cause of death, the primary cause of death for the coronavirus is the acute respiratory distress syndrome. This is the most fatal thing you can get when carrying a respiratory pathophysiology from a virus. So you see the causes here. Pulmonary edema, which is a blood clot, goes to the pulmonary embolism is a blood clot. Pulmonary edema is the swelling of fluid in the lung, often associated with heart failure and hypertension. You can also get it from drowning, aspiration of gastric contents. So you're a college student, you drink too much, but you have food on your stomach because you're trying to stay sober while drinking so you can stay up all night without blacking out. You finally go to sleep at 3 o'clock in the morning, you puke, you aspirate on yourself, your epiglottis falls open, food goes down in the epiglottis along with the acid from the stomach. The epiglottis is the airway into the trachea, which goes into the lungs. The acid burns the lungs, causes inflammation and infection, which can lead to acute respiratory distress syndrome. So there are many cases of college students who are drinking who even develop the syndrome and die because of the aspiration of gastric contents that occurs when they drink too much and eat. And I'm not saying don't drink and not eat. What I'm saying is don't drink, especially while you're in college trying to get good grades to get a good job. It's also not, it's hard on, alcohol is bad for many reasons. Moving on, drugs and toxins and therapeutic medications can cause it. You can have therapeutic reactions. People can have this syndrome. Infections, trauma, burns in the lungs. Remember we talked about the mustard gas or biological warfare agents can cause it. And disseminated intravascular coagulation, which is a system-wide blood clotting formation. This can occur when you're exposed to something like a blood thinner medication like heparin. People can be allergic to heparin and it can cause this system-wide blood clotting formation which can shut down the lungs. Among blood transfusions, so if you receive somebody's blood that you're allergic to, because blood has different glycoproteins and receptors on each of the blood cells as well for O type, B type, A type, and etc. If you get transfused with the wrong one, they can also shut down the lungs. Because what? All the blood goes to the lungs. Acute respiratory distress syndrome is characterized as a syndrome because it has clinical features that are always apparent. So it's rapid onset within 12 to 18 hours after exposure to the virus or the antigen or the acid or the chemical agent. What happens is the body undergoes hypoxemia and it's refractory to oxygen therapy, which means refractory means resistant. So even when somebody's hypoxic and they're put on high oxygen therapy in a hyperbaric tank or they wear the oxygen mask, it's refractory, it's resistant. Because when ARDS begins developing, the lungs are shutting down. And so if you consider a bottle as the surface area of the lung, as the infection fills the lung, you get 10% defective, 20% defective, 50% defective. And so even on high oxygen, only 50% of the lung is able to respire that oxygen in and out. And so what happens is the demands of the body don't change, but the effectiveness of the lungs to transpire the carbon dioxide out and bring in oxygen in, that effectiveness decreases with the disease pathology. So they become hypoxic. And I know an infectious disease doctor, and he says when people develop ARDS and they're not, they have a fighting chance, what they will do is they will turn them down onto their chest and lay them flat on the bed on the chest because the disease, the hypoxemia is a result of ventilation, perfusion mismatch. So ventilation is the oxygen going in and out. Perfusion is the heart pumping the blood in and out. So in order for the blood to receive the oxygen, you have to have it meet up every time like this. And so that the oxygen can go in, the CO2 can go out, and the new blood can take it into the body with the oxygen like that. And so when you have a ventilation perfusion mismatch, where the air is going in the lung is not where the blood is going. And so the disease can shut down the portions of the lung where the air is going. And this can cause the hypoxemia, low oxygen emia in the blood. So hypoxemia is the blood is oxygen deprived because it's not taking up the oxygen in the lung because the disease of the virus, such as the coronavirus, is shutting down the lung so it cannot take the oxygen in. So CXR means chest x-ray, and it's on a chest x-ray. I want to show you an image here. It's going to be a diffuse bilateral infiltrates. These are going to be things that make the x-ray look blurry, gray, splattered, and you will see this image. And so what this means is, why are these infiltrates, so something's been infiltrated into the lung that shouldn't be there. So these infiltrates are there due to the increased permeability of the alveolar capillary membrane due to a high neutrophil infiltration. So when you get the virus into the lung, neutrophils are one of the first ones on the scene to fight that virus. The neutrophils are part of a white blood cells, and these blood cells fight viruses, and they are attracted there due to that virus. The cells put out signals for help, attract the neutrophils, and when the neutrophils try to eliminate the virus, they release oxidative burst capsules into the area to kill the virus, but those oxidative burst species, such as peroxides and things to kill the virus, also destroy the tissue around it, which is why when you have an infection, the tissue around it becomes inflamed. Inflammation is a sign that your immune system is trying to fight that infection. So as the neutrophils are destroying the virus, they're destroying lung tissue. And as lung tissue is being destroyed, the capillary membrane becomes more diffuse and infiltrates can get in it that shouldn't be there. So this causes blood and fluid to fill the alveoli. This impedes gas exchange and shuts down surfactant production. Surfactant is what's released by the lung to keep the alveolar pockets open to bring in air. So when production shuts down, the pockets collapse on themselves and oxygen can't get into those airways, and they're surrounded by fluid and they get worse and worse. When this occurs, when you stop producing surfactant production, scientific data suggests that you have a 35 to 60% mortality rate, which is very high. There is a less severe form of this called acute lung injury. ALI is a less severe form of ARDS, but has the potential to progress into ARDS, acute respiratory distress syndrome. So here you see an x-ray of bilateral chest infiltrates here. It's on both sides of the lungs. ARDS usually affects both lungs. And here this should be a clear black looking space, and the gray spatter part you're seeing are the fluid and the infiltrates building up in the lung cavity that shouldn't be there. So the more white something is on an x-ray, the more dense it is. So you see the mediastinum here where the heart is. You see the thoracic cavity, which contains the rib cage, the spine here, the neural cord, and the heart right here. But here the lung should be black, except with some blood vessels, and here you see all of the density in the lung. Its fluid is filling that lung. Acute respiratory distress syndrome. So now we see the hypoxemia, the rapid onset, the bilateral infiltrates. There is no evidence of cardiac dysfunction, so people without heart disease are still susceptible to this, and it may involve multiple organ failure due to sepsis, hypoxemia, and disseminated intravascular coagulation. And so the sepsis, the infection gets into the blood, hypoxemia. There is no oxygen going in the blood, so the organs that need oxygen, such as the kidneys, the liver, the heart, and the brain, begin to shut down. Kidneys, you have kidney failure. Liver, you have liver failure. Heart, can lead to chest angina, unstable angina in the heart, and the brain forms encephalitis. And sepsis is the bacterial infection, and sepsis at this point usually becomes antibiotic resistance because you've already been on antibiotics to fight the bacterial infection in the lungs, and so when they put you on a broad spectrum antibiotic, there's no guarantee that it'll be effective. Treatment at this point is mostly supportive until the underlying condition resolves or the patient passes away. Remember, there are 3,000 cases of the coronavirus already reported. 116 of them have died. So you see the mechanism in the lungs. Here's the alveoli. Oxygen comes down in here. At any given moment, these are cells in the lung. You have your immune system, which is your leukotrienes, your white blood cells. They're releasing oxidants. You have proteases, which break down the connective tissue in the lungs here. These are all released when they're fighting an infection. So here you have your capillaries that surround each of the alveoli for oxygen exchange, your red blood cells that pick up that oxygen, and neutrophils, they can migrate to it through the blood, come in through the membrane to help fight the infection. The cellular debris, the platelets, the hyaline membranes, the alveolar cells, the fibrin are all in here. So this is a working thing. But then when you have an infection, notice what happens differently. Whereas this is a healthy, clean cell, you have your surfactant layer, which is produced by your type 2 cells. You have your macrophages, that's just on patrol. You have an infection, you have pneumonia that comes in, that settles in from a coronavirus. The injured alveolus during the acute phase of the inflammation pathway. So you have inactivated surfactant, you have an activated neutrophil, which releases leukotrienes, the oxidants, the PAFs, and the proteases, which break down the tissue. You have alveolar macrophages that become activated, which release tumor necrosis factor alpha and interleukin 8. These come in and inflame the tissue, but also interleukin 6 and 10 fight the virus. You get cellular debris that starts to build up in the area. You have type 2 cells that begin to be shut down. Red blood cells start to fill the cavity. People with these can often start spitting up blood, which shows there's blood in the lungs where it shouldn't be. You should never be spitting up blood. And here you have the gap formation. Fluid from the high pressure fluid in the capillaries can start coming into the negative pressure in the lungs. And so it sucks it in like a vacuum and it fills up very quickly, which is why pneumonia is a positive feedback pathology. Once it starts to happen, there's many things that all feed into this pathway to make it more and more vicious, which is why treatment for pneumonia has to be very aggressive. But if the immune system is compromised, if you're very old or if you're an infant, if you've not been abiding by the 8 laws of health, you're dehydrated, you have a weak immune system, you're already carrying other diseases such as diabetes or hypertension, these pathways are already already set up in place, and it's a domino effect. Things you can do to help build up your immune system now before it happens is to take something like zinc. You can take a 40 milligram capsule of zinc. You want to look for chelated zinc. GNC has a good brand. It's a little white bottle. It's $9 for 250 capsules. You can take chelated zinc. Zinc is very useful in the immune system, the central nervous system, the electron transport chain, and so it's very useful also in some studies have shown that zinc can help prevent somebody from being susceptible to the virus or reduce the severity of the virus. Another thing you can do is to eat healthy, eat raw foods, eat lots of vegetables, eat lots of garlic, eat lots of ginger, eat lots of turmeric, eat lots of cayenne, fresh peppers. Stay away from fried foods, stay away from cheeses, stay away from dairy and milk, which increases milk and dairy increases the surveillance of the immune system, which makes, because it has so many infiltrates and antigens in it, which causes the lungs to constantly be inflamed. People who are on milk and dairy are often more likely to have asthma, to have COPD, and to have respiratory and breathing problems, as well as cardiovascular diseases. And so we want to avoid those as much as possible, especially when viruses around the world are infecting thousands of people, and people are dying in very rapid, short progressions. Remember, ARDS is acute onset, 12 to 18 hours. When you develop ARDS, most patients die. And so you don't want to allow it to get to that point. So that's what we need to know. Also, you should be in prayer. You should be in Bible study. You should be preparing. The Bible says things like this will happen. These are the beginning of woes and sorrows. More and more things we're going to see starting to take place. The Bible speaks of these calamities. You remember the plagues of Egypt. People were getting sick. It says the 7 last plagues in Revelation chapter 16. 15 and 16. These plagues are the 7 last plagues, which means the first 3 plagues of Egypt out of the 10 plagues were pandemic. They were worldwide. And so we're beginning to see worldwide pandemics happen as time comes closer and closer to an end to wake God's people up. The 7 last plagues are much more specific, and there's particularly covenant curses upon the wicked. As you consider Deuteronomy chapter 28, the mount of blessings and the mount of curses, the wicked were to receive curses that the righteous did not receive. And so those are not pandemic biological warfares, but direct things that happen as a result of God finishing his work in the sanctuary in heaven, Christ coming out of the sanctuary and preparing to return to earth. And we see those events transpired in Leviticus chapter 18 in physical type. We see them portrayed spiritually in the book of Hebrews, and we see them portrayed climatically in the book of Revelation. All right, guys, thanks for watching. Be sure to subscribe to Protestant Church Ministries. This video, again, is not the IP intellectual content of Protestant Church Ministries. I want to thank Dr. Mark Olfert for all of his research on this pathophysiology, for his medical lectures and material. If you're somebody who's an investor or a grantor who likes to give grant money to grant writers, I'm sure Dr. Olfert would love more financial support in his research lab so he can keep producing good stuff like this to further his research. All right. This research is not meant to treat people in a hospital. If you want to know the clinical side of things, consult a primary care physician or an MD who's graduated and passed their medical boards. I have not done that yet. So thank you all. Please keep us in your prayers. If you have any questions, you can go to protestantchurch.org. That is our website. We are a nonprofit. We are here as a public service to help people. If you would like to donate, you can receive a tax receipt for your donations to help us continue to creating good videos and content as we prepare the people for what's coming both physically, mentally, and spiritually in the world as we are living in these last days. Thank you all.